Hello, good evening, everyone. Am I audible to all? Please give a heads up if I'm audible to everyone.
Yes, you are audible.
Okay,
Audible.
thank you. Welcome to another session today. We just thought we'll give a few scenarios on respiratory scenarios because we saw that in the recent recalls, quite a lot of respiratory cases have been asked. Even in the last Pakistani recall, there was one case of pneumonia with pleural effusion. So we just thought we'll do a few scenarios of respiratory system for everyone to benefit. Uh, so I think basic examination, all of us are clear. So I just thought I'll brush up pertaining to MRCPCH clinical respiratory system examination, what all you definitely have to note down and what you cannot miss. I hope my screen is visible to all.
Yes,
So
yes, ma'am.
just do an overview of what is expected. So respiratory system is one of the systems that can be expected in the others station. Like commonly the one of the four clinical stations is others, and the others can be cardiovascular system, abdomen, and neuro. Those three usually don't interchange. Neuro might become MSK, musculoskeletal system, or sometimes they can have neuro and musculoskeletal, and then abdomen. But the fourth station can be anything. It can even be musculoskeletal or it can be short stature approach, and other system can be respiratory system in the other station. And recently being increasingly asked in exam. So some of the commonly expected cases and one of the case that is one of the respiratory case that is a lot of findings, hence can be expected to kept is chronic suppurative lung diseases, because only those have all these physical signs a lot. Asthma, you may not even have any auscultatory signs. And pneumonia with effusion or empyema or pneumothorax, the child will be in acute condition. So child might be toxic looking, or child may not be comfortable and cooperative to let so many people examine. So those all may not be the main options. But then if they have one of the chronic suppurative lung diseases like cystic fibrosis or primary ciliary dyskinesia or any immunodeficiency like ataxia telangiectasia, with any RS involvement and the child is stable looking, they might actually keep those cases. Or it can be any syndromes that has chest involvement at present, like Down syndrome or Treacher-Collins syndrome or Jobs syndrome. So invariably, if it is a respiratory system case in the other station, then you can expect one of the chronic suppurative lung diseases in that. And so clinical station, as we all know, there are 4 minutes outside during which you won't be given any information about what you might expect inside. There can even be a bomb sitting inside, but you won't be told about it. And then once you enter, they'll give you a command of what is to be done. And then as soon as you enter, the 6 minutes starts, and then the command, and you'll immediately have to start doing your examination. Usually the 6+3 is arbitrary, as in you don't have to definitely finish your examination within 6 minutes, but then you do receive a knock or a warning bell at, when there is only 3 minutes remaining. And examiners do expect you to stop your examination if you have completed your examination by then. And things you cannot miss in RSS will definitely have to be mentioned and will definitely give you diagnostic clues. I've just put up a few so that it is, easy for you to remember. This slide, definitely everyone will have to remember. So devices, when you do general examination, you'll see whether the child is in distress or not. And you'll also see whether the child is looking small for age or not, whether there are any dysmorphic features that you can see, because some of the symptoms that we saw in the previous slide can also be there in respiratory system. Or you'll also check if the child has any devices attached, like any pulse oximeter or a monitor attached or an oxygen mask attached if it's a respiratory system station. Or there can be other devices like sputum pot. The pot might even contain the child's sputum. So then you might be expected, though not frequently, to check the sputum pot, check the color, and tell what you are expecting. Probably it's ABP, like allergic bronchopulmonary aspergillosis in cystic fibrosis child. Then the child might even have black stained sputum that they would have kept in sputum pot, and they might expect you to pick that up. Or if it is an asthma case, they might have an inhaler with spacer on the bedside, or a peak expiratory flow meter, or they can have crayon tablets at the bedside, or you might have to identify a Portacat or a Hickman line that the child has. Any like immune deficiency or even cystic fibrosis, who, if they are requiring prolonged antibiotics or any other medicines, they might put in Portacat or Hickman line. So those all we might overlook, but we should not miss in respiratory system. Similarly, clubbing, like most of the diseases in RS, like what we commonly see, pneumonia or pneumothorax, all those, or even asthma, they won't have clubbing. But then suppurative lung diseases will definitely have clubbing. So if you are given a command of respiratory system and there is clubbing, your immediate thought will go to suppurative lung disease. You don't have to think of anything else at all. I've put few examples like bronchiectasis, cystic fibrosis, primary ciliary dyskinesia, those all. And if there is a scar that you can see, usually it will be right lateral thoracotomy scar. But then if it is lobectomy, it can be either side, left or right. And in lungs, usually a scar in the chest will either be an ICD drain, intercostal drainage scar, which means they'll be very small. If they are large enough to be a surgical scar, then they'll probably be a lobectomy scar. In lungs, you won't usually expect anything else. Or if there was an empyema history or any complicated effusions, then they might have done bad surgery. Again, it will be a small scar because it is video assisted thoracoscopic surgery. But then if it is lobectomy scar, then it can either be a congenital cause that led to lobectomy, like CCAM or congenital lobar emphysema, or any lung carcinoma, or any other causes like that for lobectomy. Lung sequestration, so those can also be reasons. Or it can even be a tracheoesophageal fistula repair. I've put that here because trachea is a part of respiratory system, so you might have to think of that also. The child might have recurrent respiratory tract infections as your key that is given when you enter the station, and then ask you to examine the respiratory system. And then when you see if, the only thing that the child might have is a right lateral thoracotomy scar, so you will have to give one of these as differentials if you don't have any other findings. So for that, remember. And deformities, barrel-shaped chest, or pectus excavatum or perinatum, or Harrison sulcus, or any kyphosis or scoliosis that is associated, you will have to remember all of these. General approach, I think everyone is clear. That's why I haven't even put it in the slides. We'll usually start from the hand, move up the arms, and then finish the face and neck, and then go on to expose the chest. So as required in any clinical station, you'll have to use hand hygiene, which you should never forget. Develop rapport with the parent and the child, get permission from the parent and the child, and then you'll have to start examination. If all are clear, then we can probably move on to a few scenarios and practice. If anyone has any doubts, please open your mics and you can ask.
Vocal parameters or tactile parameters, is it okay if you do any one of them, or is it required that you do both?
I'm sorry, once again.
Like vocal parameters and tactile parameters, these are two things. Are both the examinations required or any one of them?
Sorry, I couldn't hear you till now. Can you please repeat whatever you asked?
Hello, am I audible?
Yeah, now you are audible, yes.
Yeah, vocal parameters and tactile parameters, are both the things required to be done, or any one of them is enough?
No, in palpation, you are expected to do tactile parameters, and then in auscultation, you are expected to do vocal resonance. You will have to do both.
In one of the MRCPCH videos, it was told it's not required to do both. The auscultatory parameters that you do, that is enough, it seems.
Okay. But then in their scheme, even in MRCPCH, if you see, both will be mentioned. And because MRCPCH is like standard, I guess they'll expect both. And one more trick that I can tell you guys is usually when we do palpation or percussion or auscultation, whichever, we would usually do like finish all areas of respiratory system, the areas, and then go on to the next one. Like when you do palpation, you'll start from the supraclavicular area and then finish at infrascapular and then go on. One thing that you can do is to save time, because you only have 5 minutes and then you have to have all findings. You can probably finish the front first, palpation, percussion, and auscultation, and then go on to the side and then go on to the back. When you do back, you'll have to check for spine, any kyphosis, scoliosis is there, a quick inspection, and then you can proceed with it, because then you might only be stuck with inspection and palpation at the end of 5 minutes, and you won't have anything to present at all. You won't be able to discuss DVs at all. Yeah, does anyone have any other doubts? One more thing is you might be expected to do ENT examination also, because upper respiratory tract, like it is a part of respiratory system examination. You can probably do it at the end if you find time, or you can tell. Usually we are expected to tell that one last line, isn't it? I would like to complete my examination with measuring the anthropometry and plotting in growth charts. If the child is about 10 years, then Tanner staging. Along with that, you will also have to tell lymph node examination and ENT examination. Those two you shouldn't forget. RS, lymph node is very important. Cervical nodes are very important. And similarly, ENT examination is very important, because, for example, if it is cartaginous syndrome, then the child might have nasal polyps. So you will have to mention that also. And you will also say that you want to check the oxygen saturation. And if you're thinking of asthma, then and there's no peak expiratory flow meter next to the child, then you'll have to tell that you want to check the peak expiratory flow of the child also. So those whichever needs to be added on relevant to the case or whatever diagnosis you are thinking of, those will have to be said. And when you summarize, you should make sure that you also mention about whether there's clubbing or not, whether there's cyanosis or not, and whether the child is in distress or not. Those three will be very important in respiratory system again. When you summarize, clubbing, cyanosis, and distress, those three will have to be mentioned. Yes, if anyone has any doubts, then we'll clarify. Otherwise, we'll go on to scenarios.
Dr. Harsha, can you repeat clubbing point?
Sorry, yes. Someone wanted to ask something. Is Dr. Muhammad Arslan?
Can you repeat the clubbing differentials you were telling before?
Yeah. Three things that you cannot miss is clubbing, cyanosis, and respiratory distress. I hope that's what you asked me.
No, I was asking about that. You were mentioning that when you find the clubbing, you will consider these differentials first.
Okay.
That I want to ask.
Okay, yeah. So they are mainly suppurative lung diseases. Examples of suppurative lung diseases can be cystic fibrosis or primary ciliary dyskinesia, bronchiectasis, or any other immune deficiency diseases that have been having prolonged or recurrent chest infections, hence resulting in clubbing.
Okay, doctor. Thank you.
Yeah, thank you. Okay, so usually we think that Harrison sulcus is seen in vitamin D deficiency only, but there are a few conditions in RS that can also have Harrison sulcus. Can anyone comment which disease you might respiratory system in which you might see Harrison sulcus?
Asthma, madam.
Yeah, that's very good. Any chronic obstructive airway diseases can have Harrison sulcus. Example is asthma. Again, barrel-shaped cyst can also be there in chronic obstructive airway diseases.
Ma'am, can you just tell me about the sputum color and disease?
Yeah, okay. Usually when we see it yellow, we'll think of any bacterial infections. And when it is green, we'll think of Pseudomonas infections. And when it is black, we'll think of fungal infections like allergic bronchopulmonary aspergillosis. Only those three.
Okay.
And if it is pinkish to red, we'll think of pulmonary edema. But then again, the child will be sick, so that case may not be expected in our exams.
Okay.
Then during examination, we have to comment on the respiratory rate also, right?
Yeah, if the child is looks to be in distress, if the child is stable, you don't have to specifically like count the respiratory rate and comment. But if the child is looking like the child is in distress, then respiratory rate will be expected. If you're commenting that the child seems to be in distress, then respiratory rate will be expected.
So, ma'am, can we count respiratory rate at least for 1 minute or 30 seconds?
It's usually expected for 30 seconds because you only have 5 to 6 minutes to examine. So they'll only expect you to check for 30 seconds.
Okay, ma'am. Thank you.
Okay. So if no further doubts, we'll go on to scenarios. And once we, start doing scenarios, we can add on a few more points so that it'll be easier for us all to remember also. So who's ready will to do the scenario.
Yes, madam. Shrikant.
Yeah. One second. Sorry, is Dr. Rohan ready?
Yes, ma'am, I'm ready.
Okay. So the outside 4 minutes, we'll skip that because obviously no information inside. So I'll just start the 6 minutes and then give you the command. Yeah, your
Okay.
time starts now. Examine
Am I-
this 5 years old boy Suhail for his respiratory system.
Okay.
Yeah, if you can start verbalizing, I'll start giving you information. You'll have to verbalize as though you're introducing yourself to the child and the parent.
Okay, ma'am. I'll enter the room. I'll wash my hands. I'll greet the examiner, and I'll introduce myself. I'm one of the child doctors in the hospital. Am I speaking to Suhail?
Yes, doctor. Hello, good morning.
Good morning. I've come here to examine you. Shall I do examination? Shall I do examination on you?
Sure,
Is it
sure.
okay?
Doctor. Yes, sir.
Okay. After that, I'll see whether Suhail is in any form of respiratory distress. Is he in respiratory distress?
No, he's not in respiratory distress.
Okay. Then I'll check whether he's having any dysmorphic features. Is he having any dysmorphic features?
No, he's not having any dysmorphic features.
Okay. Then I look at the surroundings for any devices. Are there any devices? Any oxygen device? Any meter dose inhaler? Any sputum?
No, there are no
Tablets?
devices seen around Suhail.
Okay. After that, I'll check his height and weight, and I'll count his pulse for 30 seconds.
Okay, so he is looking quite small for his like thin built for his age, and his pulse rate is around 80 beats per minute. It's regular in rhythm.
Okay. Then I'll ask Suhail to show his hand. I will check for clubbing. I will ask Suhail to press both his thumb together and look for the diamond shape. Is he having clubbing?
Okay, you can see what like you made him put his index fingers to, against each other, and then now you can see what is there.
Okay.
If
So I can see that he's having grade 3 clubbing. Okay. And He doesn't seem to have any cyanosis, no pallor. Is he having any tremors of his hands?
No tremors.
Okay. After that, I'll look at the deltoid region for the BCG scar. Is he having BCG scar?
Yeah, BCG scar is seen.
Okay. Then I'll ask Suhail to gently press his lower lid down to look for pallor. Is he having any pallor?
No pallor.
I'll ask Suhail to raise his upper eyelid to look for jaundice. Is he having any jaundice?
No icterus.
No icterus. Okay. And I'll see his nose for any stuffiness or any mass, anything like that. Is there any mass, any stuffiness?
You can see a small fleshy pink mass in his right nostril.
Okay. Then I'll ask Suhail to open his mouth and I'll look for the dental hygiene, crowding of teeth, high arch palate.
Is good.
Anything else?
No high arch palate.
I'll just have a look at his ears for any ear discharge. Is there any ear discharge?
No obvious ear discharge. No.
Okay. Then I look for in the mouth. I look for cyanosis also. Is there any cyanosis?
No cyanosis.
Okay. Then after that, I will go for a local examination. On inspection, I can see he's having a pectus excavatum. Are there any scars, any bulges in his chest?
No scars, no bulges.
Okay.
Just see what you see. That's all.
Okay. After that, I'll see for the apex beat.
Okay. Apex beat is at the fifth intercostal space, just lateral to midclavicular line.
Okay. Then I'll do palpation. I'll look for the trachea. I'll keep both my hands over the clavicular end of the medial end of the clavicle, and I'll do the trail sign. Is the trachea in the center or is it deviated?
Trachea is in midline.
Trachea is in midline. Okay, then I will look for the apex beat. I'll confirm the apex beat. Is it in the fifth intercostal space, lateral to the midclavicular line?
Yeah, it is in the fifth intercostal space, lateral to the midclavicular line.
Okay. After that, I'll look for chest expansion. I'll keep my both hands over the chest, and I look for chest expansion. How's the chest expansion? Is it equal or?
Yeah, chest expansion is equal.
Okay, then after that, I will with the ulnar border of my hand, I will keep my hand over the above the nipple, and I'll ask Suhail to tell 99, and then I'll move down. How's the vocal parameters? Is it equal on both sides?
Yeah, it is equal on both sides.
Okay. And okay, after that, I will do percussion. I'll start from the supraclavicular region and I'll move down both sides. How's the percussion note?
It is resonant but in all areas.
Resonant in all areas. Okay. Then after that, I'll do auscultation. Auscultation. I'll confirm the apex beat. Is it in the fifth intercostal space?
Yeah, you can hear the apex beat. It is normal. I mean, it's
Okay, then I will. Okay, then I look for the breath sounds in both sides. How are the breath sounds?
breath sounds are heard. What mode you want to know?
Is there any bronchial breath sounds? Is there any diminished
Vesicular breath sounds in all areas.
Okay, vesicular breath sounds in all areas. Okay. Are there any added sounds, any crepitations, any rhonchi?
You can hear fine crepitations all over the lungs.
Okay. After that, I'll ask Suhail to say 99 and I'll look for a vocal resonance in all areas?
Yeah, it is heard normally in all areas.
Okay. After that, I'll look at the back I'll do inspection of the back for any kyphoscoliosis, any scars.
There's no kyphoscoliosis or scars.
Okay. After that, I will do palpation. I'll look for the chest expansion. Is it equal?
Yeah, it is equal. Your time is up.
Okay, ma'am. Then I'll palpate the liver. Is it palpable?
Liver is
In the
not.
right.
No.
Not okay. So in order to finish my examination, I would like to check his saturation level. I would like to do a complete ENT examination. I will check for the lymph nodes. I'll plot his height and weight in the growth appropriate charts, and also if he's able to produce sputum, I'll see the color and quantity of the sputum.
Okay. Yeah. So why did you describe the findings that you elicited today?
So today I had the opportunity to examine Suhail, a 12-year-old boy who is short for his age, and he's not in any respiratory distress. He's having grade 3 clubbing, and he's having a fleshy mass in his right nostril. And on examination, he has fine crepitations all over the lungs. Putting all the findings together, my differential diagnosis would be chronic suppurative lung disease. Primary ciliary dyskinesia would be top of the list because he is having a fleshy mass, could be a polyp, plus he is having clubbing. And I could not palpate the liver on the below the right costal margin. Other differential diagnosis would be any immunodeficiency, bronchiectasis.
Okay. So what are the positive findings for primary ciliary dyskinesia? It is clumping that you said, and then a nasal polyp. What else are the positive ones?
He's small for his age. Growth retardation is there, and plus he's having chest infection also.
Okay. So how do you want to investigate this child?
So investigation, I would like to do a complete blood count. I'd like to do a chest X-ray. Then I would like to do a nasal brushing to look for the ciliary motility, and then I would like to do an echo to look for any cardiac problems. Then I would like to do exhalation nitric oxide test to see for nitric oxide levels, and ultrasound to look for any situs inversus.
Okay.
And
What is the nitric oxide level that is expected in the diagnosis that you are suspecting?
nitric oxide, the level would be less than 30. It will be less than 30.
Okay. Okay. And what are the associations of primary ciliary dyskinesia?
In 50% of primary ciliary dyskinesia, there could be a cartaginous syndrome, that is situs inversus and dextrocardia.
Dextrocardia. Okay. So did you confirm the position of heart, whether it was right side or left side when you examined?
I check for the apex beat and the cardiac pulsations on inspection, and I confirmed by auscultation.
Okay. And what are the associations with primary ciliary dyskinesia? Dextrocardia, cartaginous syndrome, then?
Then there could be volvulus, sinusitis, recurrent ear infections.
Okay.
infertility in males.
Yeah.
Yeah.
Okay, your time is up. Yeah.
Okay.
Yeah, well done, Dr. Rohan. It was a very nice presentation. So
Thank
do
you.
you have feedback for yourself? What do you think were your positives today, and what do you think you could have improved today?
Actually, I actually followed the format, na. I did the basic things, and then examination wise, I think I did okay.
Okay.
Mm,
What do you think you missed when you examined?
um, mm,
Okay.
no,
Okay.
I don't know.
Yeah. Fine. So others, do you have anything to add on to how Dr. Rohan presented? If you have any other doubts to ask, you can open your mics and discuss, or you can ask in chat.
Since he is 12 years of age, we should comment on the Tanner staging also.
Yeah. Yeah. The child is an adolescent, 12-year-old. So we'll have to
Mm.
comment TAN station. Okay. One person has asked, what are the differentials for primary ciliary dyskinesia? So any chronic suppurative lung disease, because there is clubbing, can be put as differential for each other. Because first diagnosis is PCD, you can still put cystic fibrosis or bronchiectasis or any other immune deficiency as your differentials. Other than that, since there's no, like, this child did not have any dextrocardia, I didn't put it like there's dextrocardia. But then if there is dextrocardia, then your differentials will narrow down. It can only be primary ciliary dyskinesia or cartilaginous syndrome. It can't be anything else. Because this child doesn't have, I wanted to keep a broader differential. That's why I didn't give dextrocardia. If the child doesn't have dextrocardia, then you'll have to put in all the suppurative lung diseases as the differentials.
And why can't this case be cystic fibrosis?
Yeah, that can be one of the differentials, because cystic fibrosis can still have a nasal polyp.
Yes, that's what.
Yeah.
And
Yeah.
because clubbing, nasal polyp, growth failure, these three features are present in cystic fibrosis as well.
Yeah, it can all be there in cystic fibrosis also.
Yes,
The
just by
toxic verbatim is more common in primary ciliary dyskinesia than cystic fibrosis. That was one clue. And second thing is that you might have icters also associated in cystic fibrosis, which this child didn't have. And they might even keep any of the inhalers or spacers or any vibratory machines that the child uses for clearing lung secretions in the bedside, which again was not here. So he also said all that in differentials.
and pectus excavatus is more common in PCD.
Yeah, it is seen in primary ciliary dyskinesia.
Ma'am, what respiratory findings would have been different in cystic fibrosis?
Yeah, cystic fibrosis, you might have, like I said, other systemic involvement, like there can be jaundice, or the child can even be in distress because they'll usually present in infections. I mean, any acute infection like pneumonia. So if they are presenting with any pneumonia, there will be, local findings. In here, you had diffuse findings. There was diffuse fine crepitations all over because of secretions. There is no ciliary motility. So the secretions are always stagnant. So you'll always have fine crepitations or crackles that can be expected on auscultation. But in cystic fibrosis, that is not common. Because they'll be on continuous physiotherapy for clearance of secretions, and usually they'll present with infections only. So there can be some pneumonia. So there will be local findings more than diffuse findings. But they both clinically are quite very similar. Primary ciliary dyskinesia and cystic fibrosis. If there is no dextrocardia, it is very similar. Both are very similar. Just that in primary ciliary dyskinesia, you might have hydrocephalus also as an association. So that will have to be kept in mind, because or ependymal, the choroid plexus cilia, because that will drain out the cerebrospinal fluid out. So in primary ciliary dyskinesia, that might be affected. So the child might have a large head and the VP shunt along with clubbing and respiratory system findings. So then you can put them together as primary ciliary dyskinesia. Even if there is no dextrocardia, that can still be there. And in cystic fibrosis, you'll always have any GI involvement also. The child might have a scar in the abdomen, or the child might have any icterus because of abdomen involvement, or the child might have any tablets kept like Creon or any pancreatin tablets kept in the bedside as flu.
Should we measure the head circumference in this case?
If you can see any, like when you're asking about the
Not
child's
obvious.
anthropometry at the start, and you can observe that the child has a large head, then you will be expected to measure the head circumference.
Okay.
And to look for VP shunt, if you can see obvious large head, you'll have to look
Okay.
for VP shunt and measure head circumference.
And what is the cause of jaundice in cystic fibrosis?
Because of pancreatic involvement. Okay. So R is, as you can see, the format, if you can stick to the general format, then you can easily pick up findings. Just that you won't you won't be able to find time to finish the entire RS system examination because you'll have to finish the front, the side, and the back. Otherwise, it is mainly focused on discussion. Because if the most commonly kept cases are only chronic suppurative lung diseases and it's difficult to differentiate them clinically, so it will mainly be discussion. With how will you confirm that this is a case of cystic fibrosis or a case of primary ciliary dyskinesia? So you will have to be thorough. And cystic fibrosis, if they have a case, they won't hesitate to keep. Similarly, primary ciliary dyskinesia, if they have a case, they won't hesitate to keep. That is how it is. So make sure that you read both the theory and cystic fibrosis is given in guidelines, which you will have to know for sure. There are about 4-5 pages in the guidelines. The entire thing will be expected to be known. Okay. So we'll go on to the next scenario. Who is ready? Dr. Srikanth, are you ready?
Yes, ma'am. Yes, madam. I'm ready.
Okay. So I'll time it. So again, you will have 6 minutes. We are skipping the first 4 minutes. Your
Okay.
time starts now. So examine this 6-year-old girl, Emma.
I'm entering the room, madam. Good morning. Good morning. I will do my hand wash. And how are you doing, Emma?
Hello, doctor. I'm fine.
So now today I'm going to examine your chest. Is it okay?
Sure, doctor. Yes.
First of all, I want to introduce to you. So my name is Dr. Srikanth, one of the child specialists today. So let me have a quick look around you. Is there any dysmorphic features?
No,
Okay.
no dysmorphic features.
Uh, is she having distress?
She's having slight distress.
I would like to ask about her dimensions.
Okay, she is looking thin for age and small build for age.
Okay. Emma, can you show your hands? I would like to examine your hands.
Yeah, she is showing her hands.
Is there any clubbing?
There is clubbing, as you can see in the picture. And there is this tablet kept in the bedside.
Yes. Okay. Is there any cyanosis?
No cyanosis,
Pallor?
no pallor.
I would like to have a quick look on deltoid region. Is there any BCG scar?
Yeah, BCG scar is seen.
So I want to feel her pulse. What is the pulse rate?
Pulse rate is around 120 beats per minute.
Okay. Emma, can you pull down your lower eyelid for me?
Yeah, she's pulling down. There's no pallor.
Okay. Uh, I would like to check her nose for any stuffiness or polyps. Is there any polyps?
No polyps.
Uh, Emma, can you open your mouth for me? I want to check your dental hygiene.
Yeah, her dental hygiene is good.
Any cyanosis around the mouth?
No, no cyanosis.
So I would like to examine your neck for any lumps and bumps.
Okay. There are no lumps and bumps. I mean, no lymph node enlargement that you can see.
Can you turn your neck? I want to examine your side of your neck for JVP.
Okay. She is turning her neck towards right or left? Which side?
Left side, left side.
Okay, yeah.
Is JVP is normal?
Yeah, JVP is normal.
So I want to check your lungs and chest. What
Okay.
is the shape of the chest?
Shape
Is
of
there any deformities? Shape, symmetry? Is there any deformities?
no obvious deformities that you can see.
Okay. Any scars?
There is a scar over the right chest, just below the clavicle. It's a very small scar.
Okay. Mm. What is the respiratory rate?
Her respiratory rate is around 35 per minute.
Okay. I want to palpate her chest. First of all, I want to check the tracheal position. Is
Okay.
it central?
Yeah, trachea is central.
What about apex beat?
Apex beat is at the left fifth intercostal space.
I would like to check her chest expansion. Is it normal? Are there any abnormalities in the expansion?
Yeah, chest expansion is normal.
I would like to do vocal fermitus also. Any positive findings on vocal fermitus?
Yeah, vocal fermitus is increased over the right lower areas.
Okay, okay. I want to tap on your chest. Is it okay?
Yeah, sure, doctor.
So I will percuss all over the chest areas like supraclavicular, infraclavicular, mammary, inframammary, axillary, infra-axillary areas. Is it fine?
Yeah, sure, doctor.
So what about the findings, man?
Yeah, there is a dull node that you can percuss over the right lower areas.
Okay. I would like to hear your lung sounds. I would like to auscultate all over the areas. What are the findings on auscultation?
So there is bronchial breath sounds that you can hear in the right lower areas.
Okay.
Otherwise, there's normal vesicular breath sounds in other areas.
Oh, okay. I want to check her back also. For any spinal abnormalities. I would like to palpate her back and for the chest expansion. Is it normal?
Yeah, it is normal. There are no skeletal deformities, spinal deformities.
Okay. Vocal fermitus.
Yeah, same findings.
Okay.
All findings are same as in the front.
Okay. So.
Yeah, your time is up.
Okay, I would like to complete my examination by taking vitals like saturation, pulse rate, respiratory rate, and BP also. So I would like to examine his abdomen, her abdomen. I would like to examine her ear, nose, throat. I would like to plot her growth centiles on the chart. I would like to measure her peak flow, expiratory flow rate. Yes. So I want to summarize the case. I have examined 6-year Emma. She is not in distress. She is small for his age. However, I would like to plot her centers on the chart. I can see devices like PEFR and pancreatic enzyme tablets.
Yeah.
Yeah. Mm. So on examination, there is a she is having clubbing and scar on the chest, right side of the chest. Uh, mm, uh, her tracheus appears to be central. Apex bit is normal. Vocal fermentus is increased in right lower chest, and auscultation on percussion. Dull note is present in right lower lung areas, and auscultation bronchial breathing. I can hear bronchial breathing on right side lower chest area.
Okay.
So putting all these positives in things, my differentials are like right lobar pneumonia, and it may be due to any chronic disorders. I can see icterus also. I forgot to mention in the summary.
Okay. So which chronic suppurative lung disease do you think this child can have? If you have any differentials to mention.
Would like to send the investigations like full blood count and liver function tests, chest X-ray. I want to do ultrasound chest also for any to check any pleural effusion. I would like to ask. I would like to perform spirometry also. I will involve my consultant and a pediatric respiratory consultant.
Yeah.
Mm.
Okay. Which chronic suppurative, my question was, which chronic suppurative lung disease do you think could be a differential
Maybe
for this child?
cystic fibrosis, madam, because she is small for age and she is having clubbing and icterus and her lower part of the chest involved. And she is having on the table. I can see pancreatic enzyme tablets also, and she's having the device. I think for mucus clearing.
Okay. So what can be the differential diagnosis for the pneumonia since you're thinking cystic fibrosis?
Bacterial infections like staph, pseudomonas, cepacia, Berkeley cepacia. And aspergillosis also.
Okay.
And liver involvement also there in this case.
Okay. So what investigations would you like to do?
If it is a case of cystic fibrosis, I want to confirm. I will send first of all routines like CBC, LFT, all these things, electrolytes also, and ABG and spirometry. For the confirmation, I will do sweat chloride test and gene testing, gene testing. That's it.
Okay. And for the current infection that the child has?
Madam, pardon?
Investigations for the current infection that the child has.
Chest X-ray, sputum culture.
Okay.
And ultrasound chest also.
Okay. And how do you want to manage this child?
So I will advise physiotherapy, and I will give the nutrition advice about a high calorie diet and high protein diet. I will prescribe pancreatic enzymes. I will suggest vitamins, fat soluble vitamins. I will give antibiotics, mucolytics.
Okay. So what will be your choice of antibiotic?
peptides plus aminoglycosides. If it is pseudomonas, then I will prescribe nebulized tobramycin and polymycin.
Okay, okay. If it is any other organism, if it is bronchopulmonary aspergillosis, what would you give?
I will prescribe corticosteroids and along with that antifungal medication also.
Okay. And any other bacterial infection like Burkholderia?
Then I will prescribe peptides plus amikacin, piperacillin plus amikacin, and ciprofloxacin, oral ciprofloxacin.
Yeah. Sorry.
Ciprofloxacin, madam, oral ciprofloxacin.
Okay. And what advice will you give the parents?
Uh, uh, I will ask parents to quit smoking. If they're having that habit, I will ask them to quit the smoking, and I will ask them to do the physiotherapy, chest physiotherapy for the child, and I will advise immunization, vaccinations for against influenza, all these things.
Okay.
Infection, maintenance of the proper hygiene.
Okay. Yeah. Thank you. Yeah. Thank you, doctor.
Thank you.
Yeah. So, tell me what all you did well and what all you should improve.
I think I'm a little bit nervous actually.
Not
I
nervous.
forgot some positive things while summarizing the case.
Yeah. And this
About,
nervousness will be even more when you're in a real exam, especially looking at the examiner who has a masked face and standing in front of you. It'll be even more. So the more you practice, your nervousness can come down. That's why we want to do these sessions. Yeah.
okay.
And positives, we'll talk about positives first.
Oh, I think I followed the format, I think.
Yeah. And you picked up all the signs. That itself is a very good thing because the respiratory system is very subjective. One finding that one of them field has and the other person may not elicit the same findings. Respiratory system is very subjective. So for you to pick up the pneumonia itself is a very big thing, especially in under so much stress. So that's a good thing.
Okay.
Okay. Since having real patients every day, all these cystic fibrosis and all, you don't even know when you might see the patient. So the more you verbalize, especially for such cases, the more practice you guys will get. Okay. So I know verbalization is totally different from actually examining real patients, but then the more you verbalize, you'll get the proper flow of examination, so that you'll do it very systematic when you actually do it in a patient. That is why these sessions will help. Okay.
Okay.
Yeah. Anyone else has anything to add?
In this, the differential diagnosis could just be pneumonia also, right-sided pneumonia.
Cannot be
Right-sided
clubbing. It has to be a chronic suppurative lung disease. If there is no clubbing, then you can still say an acute condition like pneumonia as a differential. But because clubbing, there is some underlying chronic suppurative lung disease. On top of it, there is a pneumonia. So it is most commonly cystic fibrosis, or it can be immune deficiency also. But immune deficiency will also have, depending on the disease, it will also have other clues. For example, if it is attacks at telangiectasia, there will be telangiectasia, and when you're looking for pallor and icterus, you'll be able to pick that up. Or Job syndrome, has its own double row of teeth or retaining of primary teeth. Those clues will be there. Yeah, so one thing that Dr. Shafaq has posted in chat is Many of us just give one diagnosis. Why not differential diagnosis? List at least 3, because in most postgraduate exams, they demand differentials rather a definitive one. And in MRCPCH clinical, they don't expect you to give one diagnosis at all. Like we always say, it has to be umbrella diagnosis only, like I said, because there is clubbing, your differential will be chronic suppurative lung disease. And then you can list all those: cystic fibrosis, primary ciliary dyskinesia.
Immunodeficiencies.
Why not bronchiectasis, madam?
Yeah, bronchiectasis. It's the most common suppurative lung disease. Bronchiectasis, you can tell. So, because tuberculosis is also can also present as bronchiectasis, so then tuberculosis can also be kept as a differential. But how many tuberculosis have we seen with clubbing?
None.
And like for clubbing to set in, you need like weeks and weeks of pathology to happen. So in acute pneumonia, even if it is an advanced stage and even if the child is very sick and all, you won't get clubbing. If it is a recurrent pneumonia or a persistent pneumonia, then you can get clubbing. But then all those recurrent and persistent pneumonia is because of some underlying pathology, like any congenital disease or immunodeficiencies. Only those will get. So then clubbing is justified because of the underlying pathology. In the exam, you will only be expected to give differential diagnosis. One diagnosis is definitely not expected. And tuberculosis is very common in South Asian countries, so you can give this as a differential diagnosis. That is true.
But in this case, we have seen pancreatic enzyme tablets and devices all around. So that is the cystic fibrosis is the first priority now, madam.
Yeah, because pancreatin is kept.
Is that tuberculosis also one of the differential? I accepting that. Just in this case, we have seen tablets and devices, right?
So your top differential will be cystic fibrosis. Like I said, when it is primary ciliary dyskinesia along with dextrocardia, you cannot, give a broader differential. Similarly, when there is pancreatic enzyme supplements that is kept in the bedside, you cannot give a broader differential. But you can probably tell like, because there is clubbing, I'll also consider other suppurative lung diseases, but they'll be kept as kept at the bottom because the child has pancreatin tablets at the bedside. I would keep cystic fibrosis as my top differential.
Okay, ma'am.
Yeah. So when you were examining, you missed the nebulizer that the child had in the picture.
Okay. I thought that is the device is for mucus clearing.
Okay, whichever. You should have mentioned that device, no? It was a
Yeah.
nebulizer that the child
But
was.
I mentioned, madam. Actually, I mentioned.
Okay.
I thought I said it is a mucus clearing device. I said.
Okay. Fine.
Okay.
Yeah, so that is a nebulizer. And then icterus, you finally caught it at the end. The picture was there for the entire some 4-5 minutes that you were examining, but finally you caught it at the end. Okay. And one more thing is we will have to ask permission before exposing the child. Both Dr. Rohan didn't do that and Dr. Shrikant didn't do that. You asked permission for examining the child, yes, but
Okay.
to remove the shirt and all, you'll have to ask permission once before examining.
Oh, okay, ma'am.
Yeah. And when I ask how will you manage the child, especially in cystic fibrosis, but any chronic case, you will have to tell that you will review the previous records of the child, whatever, past admissions, everything you will have to review. So that will be your first line that you will tell. Then you will tell, I'll involve my senior or my consultant. Those 2 lines you will definitely not miss. You should not miss. Because especially in cystic fibrosis, the antibiotic that you will start will be based on the previous sputum culture reports, isn't it? If the
Yes,
previous culture grew pseudomonas and responded to whatever antibiotic they gave, if it was piptaz, then you'll start off piptaz. If the child didn't respond to piptaz, needed a higher antibiotic like meropenem or colistin, then you'll start off only those. So reviewing previous records will be very important. And investigations, when you say, you will have to say like a confirmatory test and supportive test. Confirmatory test is how will you confirm cystic fibrosis? So how do you confirm cystic fibrosis?
sweat chloride test and gene testing, madam.
Okay. So sweat chloride test is confirmatory or only gene test is confirmatory?
Gene testing. Gene testing.
Sorry?
Gene testing, madam.
Okay. Does anyone else want to try answering this question?
CFTR gene test, ma'am.
Yeah, gene testing, he also said gene mutation itself is confirmatory. I'm asking if there is any other.
Ma'am, if sweat chloride is more
ERT.
than 60, then
Yeah.
we can still consider this as cystic fibrosis.
That's very true and very good also. Uh, so you do sweat chloride testing as a screening testing, but then it can be confirmatory when the value is more than or equal to 60 millimoles per liter. If it is not, and it is only between 40 to 60, then you will have to proceed with gene testing. What your guidelines says is if your sweat chloride test is more than 60, you will have to do gene testing. Just because it is autosomal recessive and they are planning for further children, it is required. Otherwise, for your diagnosis per se, if it is more than 60, you don't have to do gene testing. But if it is 40 to 60 or 30 to 60, then you'll have to do gene testing. And 2 mutations must definitely be there for you to confirm the diagnosis of cystic fibrosis.
Yes, madam. Actually, I forgot. Yes, this is the MCQ in the third step.
Yeah. And if it is less than 30 or less than 20, but you're still suspecting, you have strong suspicion of cystic fibrosis, then you can still go ahead with gene testing. And again, you'll have to have 2 mutations because it is autosomal recessive. You're supposed to have 2 mutations to confirm the cystic fibrosis diagnosis. If both are negative, then cystic fibrosis is unlikely. Then you'll have to search for alternative diagnosis. And the other ones are, you'll see the potential difference.
And screening test, IRT.
Yeah. In newborn period, you'll do immune reactive trypsinogen. So what are the GI complications in cystic fibrosis?
Rectal prolapse, meconium ileus, distal intestinal obstructive syndrome, cirrhosis, portal hypertension.
And then cystic fibrosis related diabetes, that is also a
Yes,
complication.
diabetes. Yes, ma'am.
Yeah, CFRD. CFRD will usually set in about 10 to 15 years after onset of.
Adult, yes.
Yeah, and cirrhosis of liver is also expected about 1 or 2 decades later after cystic fibrosis, which means again second decade or so. Okay. So annual follow-up, what will you do? Okay, I'll finish this. Advice to parents will be what all you said. They'll have to quit smoking, and then they'll have to also avoid crowded areas to prevent infections because cystic fibrosis is prone very much to infections. And then they'll have to take care of vaccinations, and then they'll have to be on regular follow-up. That's like very important, both with physiotherapy and with pulmonologists. And they will have to do physiotherapy at home also. All those secretion, sputum clearing device techniques all will have to be followed. Okay, annual test follow-up, what all will you do for cystic fibrosis?
Growth monitoring, madam. Sugar.
Yeah, complete blood counts, urea, creatinine, and then
Urea.
electrolytes. If
Sugar.
warrant
Sugar.
have to be checked, is sugar, random blood sugar has to be checked. Vitamin levels might have to be checked. Parathormone levels might have to be checked. Okay.
Why, madam? Parathormone
Um,
is the main specific reason.
Yeah, it can have multiple endocrine involvement also.
Okay.
Okay, and if the child is on tobramycin, then trough levels of tobramycin will also have to be checked.
Okay.
Okay, so do you know when we should usually check if the child is on tobramycin, when should we usually check the tobramycin blood levels? Okay, it is usually checked before the 2nd dose and the 8th dose. All this, whatever I am talking, everything is given in guidelines. It has to be checked just before the 2nd dose and before the 8th dose. Okay, and complications, you can name it system-wise also. As in, if it is respiratory, then the child can develop asthma and recurrent wheezing episodes. Nasal polyps will be there, so sinusitis will be there. Recurrent chest infections will be there. Aspergillosis, the child can end up with aspergillosis. Because of recurrent chest infections, the child can even end up with cough pneumonia. But those are very rare and very late complications. And then GAT, the child can have failure to thrive. The child was very small looking, so failure to thrive can be there. And others that you said, meconium ileus, distal intestinal obstruction syndrome, rectal prolapse, those are all was fine. And then hepatic also, hepatic and pancreatic, all those also you will have to tell. Sorry.
The malabsorptions and cirrhosis, total hypertension.
Cirrhosis, cholestasis, polylithiasis can also happen. And then pancreatitis can happen. And CF-related diabetes, that also you'll have to tell. And then endocrine or metabolic wise, there will be metabolic alkalosis, no. So that can also be. And malabsorption, so there can be osteopenia, hyperparathyroidism, those features. Then that there can still be infertility. And because it is a chronic disease, for any chronic disease, again, you can put depression as a complication or association. Because the children won't understand much and they'll go into depression because they'll have to take so many medications when other their friends don't. So those all you can put. And
in advice, we can in advice, madam, genetic testing of parents.
Yeah. Like I said, autosomal recessive. If they are planning for children in future, then they will have to undergo gene testing too. Okay, and what multidisciplinary team will you involve? So when
respiratory, pediatric respiratory consultant, dietitian, physiotherapist, endocrinologist, gastroenterology. I think cystic fibrosis specialized nurse.
Yeah, good. So there is this team called cystic fibrosis team. So when they ask about MDT, the first word that if you tell, they'll be impressed. So you'll have to tell that I'll involve the cystic fibrosis team, which comprises of pediatric pulmonologist, pediatrician has to be there, and then everyone else that you told. And other than that, you'll also involve geneticists because gene testing is being done. And then psychologists because it is very a big thing for both the parents and the child. So psychologists will have to be involved, and because the child will start going to school. This child is also 6-year-old, so you'll have to liaise with school nurse. That also you'll have to tell, and for that you'll also require social worker for all these. Okay. So the entire guidelines of cystic fibrosis for 4-5 pages that you'll have to know in and out because they can ask anything. Like I said, if this is the first time, like what antibiotic you'll use. If it is Pseudomonas aeruginosa and this is the first time that the child is coming with the presentation, then prophylactic antibiotic, you'll put ciprofloxacin, and the child might require nebulized colistin. If the child is come with pneumonia, then you'll start off tobramycin and ceftazidime. Instead of piperacillin tazobactam, you'll have to give ceftazidime, and nebulized colistin is preferred. If the child seems to have, there's no clearance of sputum at all, the child seems to have chronic infection, then you can give continuous nebulized antibiotics like tobramycin or colistin. You'll even give for 3 months and all. So everything is given in the guidelines and you'll have to read the whole thing. Everything in and out about cystic fibrosis will be explained. Recently, there's also one communication scenario, over the last 1 or 2 years. What if the child got exposed to a cystic fibrosis child got exposed to chicken pox and the mother is angry? So what will you do? Okay, so there is this pediatric guidelines that is given out by NHS and NICE. I can even share the guidelines in the group. So you will have to follow that. If you're for MRCPCH clinical, all guidelines, you will have to follow that only. There's both pediatric guidelines and neonatal guidelines. So Dr. Rukshana, I'll share that in group after the session is over. Yeah, thank you. Okay, so I have one more scenario. If you guys are up for it, then we'll proceed with that scenario also.
Yes, ma'am.
We'll do now.
So who's ready?
Ma'am, can I do?
Yeah,
Can I do?
Murtaza had already volunteered to do.
Oh, okay.
Murtaza, are you available?
Yeah, I'm available.
Okay, so I'll time it. Okay, so your time starts now. Examine this 5 years old boy corner.
I'll enter the room, wash my hands. Hello, this is Dr. Murtaza, one of the doctors in OPD today. Am I talking to Konur,
Hello,
Konur's
doctor.
mother?
Yes, doctor.
Hi. So I'll be examining Konur today. Is it fine with you?
Yes, yes, sure, doctor.
Hi, Konur. We'll be playing today. So if you have any issues, any pain, any distress, let me know. Okay.
Yeah, sure, doctor.
So I will see if there is any distress with the Konur. If he is breathing fine and he is not in distress.
Yeah, he's not in any distress.
Any devices which are in and around Kanur, which are present.
No, there are no devices.
How is his height and weight?
He is looking slightly well built, overweight for his age. Otherwise, he is okay.
Okay. So with regards to dysmorphic facies, I can see that he has some spots on the legs, which are like pigmented spots. Looks like eczematous. It has been scratched. It looks in the lower limb, and the facies also on the forehead looks broad to me, and the nasal bridge looks a bit like broad to me. Okay. So this pictures of dysmorphism of a Konur, can you just raise your fingers and make a diamond like this? And
Yeah, he is doing.
no clubbing.
No, no clubbing.
Okay. Any tremors?
No, no tremors.
How is the any Koilonychia platanichia?
Sorry, I couldn't hear.
Koilonychia platanichia?
No, no nail changes.
No nail changes. How is the pulse like? What is the pulse rate?
Pulse rate is around 100 beats per minute.
BCG scar is present.
Yeah, BCG scar.
Okay. So any axillary lymph node present?
No.
Okay. Konu, can you just show me pull your eyes like this, like I am doing? Any pallor?
No pallor.
Can you just pull it from upwards as I am doing? Any icterus present?
No icterus.
Okay. Can you just open your mouth like this? Ha. Like,
Yeah,
how are the teeth like? Dental hygiene and
yeah,
all?
dental hygiene is good. There's no abnormality with the teeth that you can see.
Okay. Any high arched palate?
No.
Okay. So I will just examine the ear also. I cannot see any deformities in the ear. Any discharge from the ear?
No, no obvious discharge certificate.
I'll examine the neck for any lymph nodes or any swelling, thyroid swelling.
No. No lymph nodes or thyroid.
Okay. Then I'll now, Konur, can I just open your shirt and see your chest now?
Yeah, sure, doctor.
Thank you. So I'll just do the examination of the inspection of the chest. I'll do it from the right side of the bed and the bed end. The chest is symmetrical.
Yeah, chest is
Shape.
symmetrical.
Shape is fine. No abnormality of the shape, anterior posterior diameter. Anything is not like normal. They are normal.
Yeah.
Movement of the chest is fine.
Yeah. Movement of the chest is
Any
normal.
okay? Any scars, sinuses, or any pigmentation or dilated veins on the chest?
Oh, no. No scars or dilated veins.
So I'll just warm my hands now. And Punur, I'll just touch your chest now. I'll see for the tracheal position, keeping my 3 fingers and palpating with the middle finger. Is the trachea central?
Yeah, trachea is central.
I'll see for the expansion of the chest. I'll put both my hands below the chest in the lower part and see for the expansion. Is it symmetrical?
Yeah, it is symmetrical.
I'll check for the apex beat. Where is the apex of the heart located?
It's in the left fifth intercostal space at the midclavicular line.
Okay. And I'll check for the vocal premises with the ulnar border of my hand on both the sides. Is it equal on both the sides? And
Yeah,
I'll ask, okay. During
yeah.
this, I'll ask him to say 1, 2, 3, 1, 2, 3.
Okay.
So,
The vocal parameters is slight on the left side.
which area of the left side? I am seeing the different areas of the
Uh,
left side, like supraclavicular, subclavicular, mammary, and inframammary areas. Which of these areas?
It is in the upper areas.
Okay. Okay. Now, Konur, I'll just do thumping on your chest like this. Okay. So I'll check for the percussion nodes on both the side, left side and the right side. How is the percussion node on the left upper border? Where it was like I was getting tactile, where I was getting tactile.
That's a dull note. That's a dull
Okay.
note.
On that side, and the other parts are fine,
Yeah, other parts it is resonant.
resonant. Okay. I'll just auscultate now. So, I'll just auscultate for the normal sounds. How is the like breath sound? Is it vesicular
You can hear normal vesicular breath sounds all over.
all over the chest? Okay. And any additional sounds in the form of crackles or wheeze?
You can hear crepitations over the left upper areas.
Left upper area. Okay. I'll check for the vocal resonance on that part, left upper area.
Yeah, it is similar to palpation.
Okay. Now I'll just see your back. So I'll examine for any kyphosis, scoliosis, in any scars or pigmentation on the
No.
back.
No deformity.
I'll palpate the back and see for the symmetrical expansion of the chest from the back also.
Yeah, findings are similar to the front.
Okay. So on percussion also it is the same?
Yeah.
Okay. And I'll do the auscultation of the back also.
Okay.
So I would like to complete my examination by checking all full vitals, including the saturation, and I would like to plot him on an appropriate age and weight appropriate charts for him. I would like to examine his abdomen and see for the liver. I would like to do his full ENT examination during this.
Okay. Yeah. So summarize your findings.
So today I have examined Konur, who is a 5-year-old child who has presented, who is there with dysmorphic facies and some eczematous dysmorphic facies in the form of broad nasal bridge and prominent forehead with some eczematous lesions which are present on the upper limb, on the forearm, which I could see. On examination, there is no clubbing present, no cyanosis, and no positive findings are present in the eyes or the mouth. On examination of the chest, the positive findings which I got was vocal fremitus, which was present increased on the left upper part of the left upper lobe of the chest, along with a dull node present in the same area, and tactile vocal fremitus also increased in that area. So consolidating my findings together, I would like to put diagnosis of left upper lobe pneumonia on the background of some like syndrome with maybe or on the background of immunodeficiency.
Okay. And which immunodeficiencies would you think of based on your findings? I mean,
So since the immunodeficiency which we'll think of is of like he has eczematous lesions with a pneumonia in it. Well, I'll put a differential of hyper IgE syndrome, that is Job syndrome, as one of my differentials. Second, it can be due to some other primary immunodeficiencies like chronic granulomatous syndrome because of his early age, it in which it can be there, and it can be like secondary immunodeficiency in the form of like HIV infection leading to pneumonia and skin lesions.
Okay, so how would you like to proceed with this child?
So first of all, I would like to see the previous records of this child which are available, and I would like to involve my senior in this. I'll proceed with like I'll take the previous history of records, see for any recurrent infection, chest infections for him. I'll see for like what all are there. Then I'll go ahead with investigations. In the investigations, specific investigations and supportive investigations. For the like in this case, for the supportive investigation, I'll first take a chest X-ray to confirm my finding of right upper lobe pneumonia, which is there. I'll see for the counts, total blood count, see for leukocytosis in that case, if it is there. For immunodeficiency, I'll specific confirmation of my diagnosis. I'll go ahead with specific immunoglobulin levels to see and see the levels of different immunoglobulins. And if I'm suspecting IgE, high job syndrome, it will be like a hyper IgE syndrome more than 500. It should be there in that case.
What are the complete blood count findings in if your diagnosis is hyper IgE syndrome?
So it can be like WBCs can be increased, decreased, or it can be even normal in the case of hyper IgE syndrome. And there can be like HB and platelets are normally not involved in that case.
Okay, okay. So if it is hyper IgE syndrome, how do you want to confirm the diagnosis?
So the confirmation of the diagnosis will be basically by genetic test with like levels of IgE. If it is more than 2000, it is like confirmatory along with the genetic test, which will be for the, I think, STAT3 gene. I'm not very sure.
Okay. So what are the modes of inheritance?
So there are basically two modes of inheritance of Job syndrome: autosomal dominant and autosomal recessive. For this case, in which they are divided as type 1 and type 2.
Okay. So how do you want to manage this child?
So for the management, I would like to involve the multidisciplinary team for this. In the multidisciplinary team, it will be like first the pediatrician, along with the pediatric pulmonologist, the immune doctor, immunologist, the genetic doctor, and the skin doctor will be involved, along with the specific nurse for this. And first of all, I would like to address the current issue of pneumonia. I would like to treat it with antibiotics. And for overall, sorry.
What antibiotic would you prefer?
So in this case, I would like to prefer third generation cephalosporin, ceftriaxone, along with vancomycin, because the most common organism which I am suspecting is Staphylococcus aureus in these cases.
Okay, okay.
And then for the specific management, this will be like they will be on long course antibiotics because they are known to have recurrent infections. And the specific treatment for this is bone marrow transplantation only, like definitive treatment.
Okay. Would you want to give
Pardon me?
to talk? Someone wanted to say something? Okay. What was I asking?
What do you want to give you?
Put the child on prophylactic antibiotics.
Yeah, they are normally have to be put on prophylactic antibiotics because they will have the chances of recurrent infections.
Okay. What are the types of infections that you can see in Job syndrome?
Yeah. So they are prone to have recurrent first respiratory tract infections in the form of pneumonia, in which the organisms is mainly Staph aureus, Streptococcus, and also Haemophilus. They are also known to have recurrent skin infections, staph and skin infections, and they are mostly cold, like it won't show much signs of inflammation. These are the most common infections.
Okay. And will you be able to tell why the child looked very, slightly overweight when you asked for dimensions?
Mm, this not, no, I can't think of a reason.
Okay. Okay. Yeah. Fine. Okay. Thank you, doctor.
Thank you.
So tell me your positives and what you thought you could improve.
Lots of things to improve. Positives. I couldn't pick up myself. You need to tell me.
We should be self-appreciative, and then we'll get that confidence to perform. So yeah.
I tried to stick on to the performer. Like I tried to cover everything in that performer, although I might have missed something. And while summarizing, I was a bit flimsy, like unable to put the things in a proper fashion.
Yeah, that's true. So you were able to pick up everything, as I said for Dr. Srikanth also. You were able to pick up the findings and put it together as pneumonia. That itself is, like I said, RS is very subjective, so that itself is a very good thing. And you stuck to the schema, this format. You were very systematic. All that was very nice. And when you summarized also, you made sure that you put in all the points together, and then you gave an umbrella term, and then like immune deficiency, and then you went into differentials. And we were discussing in chat box also. So one of them said that it can be Viscott-Aldrich syndrome, which I agree, because my differential would also have been to Job syndrome, Viscott-Aldrich, because that also has eczema. Both Viscott-Aldrich and Job syndrome can have eczema.
Right.
So it is an immunodeficiency disease. So other than CGD, you could also say Viscott-Aldrich syndrome, but it should also have sinopulmonary infections. This child has pneumonia, just that there's no obvious sinusitis that you could pick up here. Maybe if a proper ENT evaluation was done, we could have picked up sinusitis also. And another question that I had asked was why it's a bit okay. That is because of steroid use. And they do give a short course of steroids for eczema. If the child
That's right.
if the parents continued giving oral steroids, and the child can become slightly overweight. Okay. So 2-3 points that is common for all of you is we should look for scars on the lateral side, lateral thoracotomy scars. You expose the chest in the front, and you just ask for scars. I know that verbalizing is completely different from how you examine, but then only if you verbalize and only if you know to look for it, you will actually do it in exam. That is why you will have to look for the scars in the axilla. So that alone you'll have to remember. So like you'll have to ask them to put the hand like this and then check on both axillas. Only then the examiner will know that you know where to look for the scars. So that was one point. And second, you only have 3 minutes for discussion. All of you are summarizing for a minute or more than that. You'll have to cut down your summary to 30 seconds. You cannot summarize more than 30 seconds because identification of clinical signs, clinical reasoning, management planning, all three will come in 3 minutes of discussion. Identification of clinical signs will come both in examination of 6 minutes and in discussion of 3 minutes. But clinical reasoning and management planning, 4 marks you'll get only in those 3 minutes. If you lose 1.5 minutes in just summarizing, you're not giving examiner time to assess you to give you marks only. So you lose those 4 marks. If examiner doesn't ask question about management planning, you only won't get 2 marks. No, they cannot score you for something they didn't even assess you upon. So obviously they'll give 0. So try to reduce your time duration of summary, all of you. Keep it under 30 seconds. And this will come only if you keep verbalizing, only if you keep practicing. For example, you will have to imagine that you're examining a cystic fibrosis child. So then you'll start from introduction till I'll complete my examination. You'll have to try to finish the whole thing in 6 minutes, and then in 3 minutes you'll have to verbalize and try to because you know the findings, isn't it? Even now we practice, so we'll know that what all are the positive findings for cystic fibrosis on examination. So you'll have to try summarizing in 30 seconds. The more you practice, the more you'll be able to reduce. You yourself will be able to judge, okay, this is needed in summary, okay, this is not needed in summary, so we'll have to cut it down. For example, for the cystic fibrosis kit that we did, I can probably summarize like, so today I examined 6-year-old child Emma. Emma was slightly in distress with a respiratory rate of 35 beats per minute. Otherwise, did not have any dysmorphic features. She looked small, built for age. Though I would like to confirm by plotting in a growth chart. She also had a nebulizer attached to her. And on further examination, I could see that she had clubbing, though there was no cyanosis or pallor. And her pulse rate was also slightly tachycardic at 120 beats per minute, probably because of the tachypnea and distress. And then I could find that she also had right low zone pneumonia findings like increased vocal fremiters, dull note and percussion, and um, bronchial breath sounds and crepitations on auscultation. So I would like to give a differential diagnosis of chronic suppurative lung disease. Sorry, I left clubbing in summary. Chronic suppurative lung disease like cystic fibrosis, because I also noticed crayon tablets on the bedside. Or it can still be other chronic suppurative lung diseases like primary ciliary dyskinesia or immune deficiencies, though I would like to keep them at the bottom of my differential diagnosis. And if you're giving exam in the in and around India, Pakistan, then tuberculosis can also be a differential. So I think I came around, like my summary came around 45 seconds because I was looking at the time. So the more you keep, verbalizing like this, the more you'll be able to club and shorten your and that is very important because you need to give the examiner's time to ask.
Does summary include does
Yeah.
summary include DDs as well?
Yeah, when you summarize, you can directly go on to differential diagnosis. Yes, you don't have to wait for them to ask you the differentials. That only saves you time and the question.
Do we say our differentials even before they ask?
Yeah, that is okay because that is part of summary, so you can tell. And one more thing, I've written a few points from whatever these three people did so that, I can just give it as general points. So one thing is you'll always have to look for dextrocardia. So when you look for apex impulse and when you look for apex beat, especially when you're palpating, you'll have to put both your hands in front of the chest and look which side you can feel the apex beat, whether it is right or left. Both in RS case and in CVS case, that is important because in CVS they can keep a case of dextrocardia, and in RS it can be primary ciliary dyskinesia or cartilaginous syndrome. So that is there. And second, you'll have to compare both sides for whichever palpation, percussion, and you'll have to compare it on both sides, auscultation also. And you'll have to get permission for exposure. Before you are trying to remove the shirt, you can probably do that together with, asking for permission. Is it okay if I quickly check your hands and chest? I'll make sure I don't hurt you. I'll just remove your shirt and make sure I put it on later. So at the end, when you're completing, after you finish auscultation, you'll have to thank the child. So that will also be expected. And when you thank the child, you can say like, okay, I'll help you dress. And the examiner will be like, okay, that is okay. Because examiner also knows that you don't have time. So they'll be like, that's okay. But then you'll have to show that you're compassionate, that you're thanking the child, that you will help the child. Just like you undressed him, you will help the child dress also. That you will have to do. And one more thing, in RS, it is not mandatory to check JVP. Even in CVS, it is not mandatory to check JVP. When you in CVS, you will definitely have to comment that I would like to complete my examination with JVP, BP measurement in all 4 limbs, checking saturation. In RS, you can include that again there. You don't have to, put about 20-30 seconds in checking JVP because the child to lie down in 45 degrees and then turn their child's, head, and then you'll have to go down and check for JVP. You don't have to do that because you might miss the important points otherwise. So I would like to complete my examination with JVP. You can put it there. You don't have to examine. And ENT examination also, if you are able to quickly check, then that is fine. Again, another 20-30 seconds for ENT, full ear, nose, throat. Otherwise, you can say that also in I would like to complete my examination with JVP, ENT examination, saturation, oxygen saturation and all that. So devices you shouldn't be.
Now, one question. In this scenario, you just said examine 4-year-old Surveen. You did not mention any system. Does
Yes.
it come like this in the exam without mentioning any system?
You've been discussing RS, I didn't specifically put it, but in general, in other station, it is very common to say just examine this child. If that is given, then you'll have to do general physical examination and proceed. And usually in system examination, that won't be the command. If, for example, if the child has short stature, they would want you to pick up the short stature and then proceed with it. Or maybe the child has some neurocutaneous marker like a port wine stain or multiple cafe au lait spots. They would want you to pick that and then go into neurological examination or any other relevant examination. For in those cases, they will tell general physical examination and proceed. For example, if it is a mucopolysaccharidosis case, they'll just say GP and proceed. You'll have to pick up the course faces and then do a head-to-toe examination, picking up all mucopolysaccharidosis signs, and then they would expect you to go into some system examination, either neuro or abdomen, or you can even do CVS examination. I mean, whichever. But commonly preferred one system for MPS is abdomen examination. So it is very common.
Ma'am, in neurofibromatosis, neurological examination is very vast. So, like, we can't, that's not possible to complete even in 10 minutes.
So usually I prefer you to do motor system examination. So it is always better to clarify with the examiner which one you want to do. For example, I picked up multiple cafe au lait spots. I would like to proceed with neurological examination. Can I do motor examination first? You can ask the examiner also. If they say okay, then you do motor examination. They'll usually tell what they are expecting when you put a question like that, because they know that you only have 4-5 minutes. So they won't like beat around the bush and all. They'll be clear with their command. That is how MRCPCH clinical usually works. There are no beating around the bush at all with the examiners. They'll be very clear cut with what they want, what they expect. So whenever it is general physical examination proceed, you can always ask them if it is okay to proceed with this system. Some like our native examiners, sometimes they get it confused, mixed up with our own postgraduate exams. So that has happened for me also. When I ask the examiner, they'll be like, you do whatever you feel like doing, and then they'll just observe. So that, that can also happen, but that is not the usual format. The examiners will be very clear cut with what they want.
Dr. Harsha, I have one question that in a case of any systemic examination, you have to do the first that system, like in respiratory, we do the respiratory first and then we go towards the relevant, or we can do the relevant first and then move towards relevant systemic examination.
Sorry, what is it? Relevant examination? I didn't catch you. Dr. Mohammed Aslan, am I audible to you?
No, sorry. Probably, I think there was an issue with the internet. I'm asking that in case of any systemic examination, we have to do the relevant examination initially, or we can do it after doing the systemic examination, like in case of the test.
General examination.
Ma'am, he's telling, suppose if it's an RS case, so whether we should first do the RS examination, then the remaining system examination later, or first the system examination and the last.
What he's asking, should we do other systems also, like cardiovascular or neuro? No. You won't even have time to finish RS. Or whatever command is given, we won't have time, or we'll have just enough time to finish whatever command is given. So
ma'am, all systems have to be done in history station, right?
History station.
No, ma'am.
History station. Do we need to?
Yeah.
Ma'am, in history station, do we need to, that there is a format which includes all the systemic questions as well, no ma'am?
Screening you will have to do in history station. Yes. So you elaborate the history of present birth history and all, and do quickly system screening for other systems. Yes, in history you will have to.
I have one question. Actually, what Dr. Aslan want to ask is that commonly what we do in our clinicals in India and Pakistan commonly, we do is that if it is a command examine the respiratory system, we will first do all the steps of the respiratory system, and if they say respiratory and relevant, then we do the steps of GPE. But in MRCPCH, they say that you start with the hand, first to the GP and then move to respiratory. This is the problem that we want to clarify, that whether we have to just start with the respiratory system and then do GP like we do in our common FCPS exams in Pakistan, or we have to do first the GP and then move to respiratory? This is the question.
Physical examination is that you follow in MRCPCH clinical is quite or very different from what we follow in our postgraduate exams. In our postgraduate exams, we'll be like doing head-to-toe examination, look for anything and everything. But in theirs, it will be even if you do general physical examination, it will only be pertaining to the system that you do. For example, when you're doing neuro examination, you're doing motor system examination, you start from hand and you look only for dysmorphism. Like you don't look for clubbing in neuro examination. I hope you get what I'm trying to tell. Only the relevant examination that is important for the system that is expected. Just like you do upper respiratory system before starting respiratory system in our postgraduate exams. For them, they expect you to do whatever general physical examination is relevant for that system. That is expected is. So you'll start from hand and go up axilla and then head and neck, and then you'll quickly move into the system whichever you want to do. And then like when we'll do head to toe examination. We'll check off lower limbs also. But in their format for abdomen, RS and CVS, they'll expect you to do lower limbs at the end. Once you finish the entire system examination, or like you finish entire CVS examination, and then you have time. You'll check for liver. You'll check for pedal edema also. And those will be at the last. But our system is like we would have checked pedal edema at the start itself. We would have said no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema at the start itself. So that is where it varies. So we will have to start from hand, no matter what the command is. Yes, Dr. Muhammad Aslan. So you'll start from hand, you'll go up, you'll finish face and neck, and then you'll go into your relevant system examination, and then you'll complete with the lower limbs. But if it is neuron, they want you to do motor system examination, you will see hand and go on to face and neck, and then you can move on to motor system, whichever limbs they want you to do. So sometimes they might even just say, do motor system of all the limbs. Then you'll have to do both upper limbs and lower limbs. Yes, thank you. Okay, hope you all had a nice session. If anyone else has any other doubts, otherwise we'll wind up the session.
Ma'am, next we should have one on a neuro session.
Sorry, I didn't hear you. Next session?
Should be on a neuro cases.
Yeah, sure. We'll definitely consider what you're telling. We'll do neuro the next session. Okay. Thank you, everyone.
Thank you.
Yeah.
Thank you, ma'am.
Thank you. If you have any doubts, please do ask in the group. Thank you.